do you think this little poor heart, he's injured, what do you think he's gonna feel like? What are we gonna feel like when we have? And when you're thinking of symptoms, take each organ. Like, okay, what is the brain gonna do? What are the lungs gonna do? What's the liver gonna do? What are the kidneys gonna do? What is the skin gonna do? So when you think of like signs and symptoms, like associated hurt organ. So what do you think? Decreased perfusion. What's gonna happen? Confusion. Not getting blood to the brain. Pardon me? Shortness of breath. The lungs are not gonna get perfused. Chest pain.
Cool extremities.
Cool, pale extremities. Pardon me? Tachycardia.
Decreased urinary output.
Yeah, more decreased urinary output. You would have a low urine output just because the blood is not perfusing those kidneys. So let's see if those are on here. Dizziness, fatigue. I think you guys got all these. So there's the hallmark symptoms for shock. Don't worry about the early, late signs, but really it's going to be tachycardia, which you guys said. Respiratory rate's going to be up, but blood pressure is going to be down. Those are the three hallmark symptoms of shock. So that's what you're going to be looking at. Normally, we need adequate blood flow through all the organs and tissues, because if we don't, then those cells are going to die, and the heart is going to kind of increase and try to get sufficient blood volume and oxygen to the respiratory tissues. But the thing is, as it increases, it's not going to be able to keep up for long periods of time. Eventually, it's going to give up. So the pathophysiology, did this go on both sides? Okay.
You need it over here.
All right. Oh, you're one. So pathophysiology is really just kind of any oxygen, impairing the oxygen delivery of the tissues. No matter what type of shock it is, you're going to have hypoperfusion. So we're going to have less blood flow getting to the tissues. The cells then get deprived of their nutrients that they need. The body does struggle to survive. And our goal is, one, to recognize it early and to restore that homeostasis. We need a equilibrium. Glycogen gets used up in the clotting cascade, and we'll talk more about that later. Vascular response really depends on what is happening to your blood pressure, whether it's going up or down, and those medications will be dependent on that. But usually for blood pressure regulation, you learned about this, I think, in A&P, the angiotensin, renin-angiotensin cascade. But we're looking at blood pressure regulations. Do you see this number up here? You guys have seen it. MAP?
Yes.
I think it's 93. Yeah, 93. So that means that our kidneys are getting perfused. Our tissues are getting adequately perfused. So when we're back in ICU, sometimes the doctors will try, or especially renal doctors, they'll titrate medication according to their MAP. So above 65 is normal, and I think that's on there, to get adequate tissue perfusion. When that MAP gets a little bit lower, we start to worry about it because their tissues are not getting perfused. So we do pay attention to that MAP level along with the blood pressure. So when we're in shock, there's 5 mechanisms to restore oxygenation, or 4. The sympathetic response, that's what increases the heart rate and blood pressure. We're going to increase contractility, so there might be a short increase of cardiac output at first, but then it goes down after that. You have the renin-angiotensin activation. So that is making sure that we're keeping fluids with inside the body. We're not gonna, that's why we have decreased urine output. Increased respiratory rate, you already know that. And increased catecholamines and cortisol because we're using all of our glycogen stores right now for energy, but eventually those are gonna run out. And then after that, it turns into they're using muscle for energy. So we don't want to do that. Again, here's the blood pressure or the signs and symptoms of shock. So there's different stages of shock. I'm not too worried about the different stages of shock. I want to know what each organ is doing in shock. So I'm going to move to a different one that I like better. So what are our respiratory effects of shock? We kind of talked a little bit about them. You said shortness of breath. What else can our respiratory do? Tachypnea, because it's going to speed up because we need to get more oxygen to the body. Labored breathing, so you might see rib retractions, nasal flaring. Think about all those assessments that mean that your air hunger. Crackles, we might start hearing fluid in the lungs. Decrease arterial O2, increase CO2. Pulmonary edema because fluid is starting to leak out of those alveoli, which leads to ARDS. Cardiac effect, I'm not going to click it yet. So we talked about tachycardia. What else? Chest pain, blood pressure. What's happening? Hypotension. What else is happening to the heart? Dysrhythmias, yeah. So you might start seeing some dysrhythmias, increased heart rate. So heart rate would be high, chest pain, MI. So maybe their troponins are starting to, we're going to check troponins. Are they starting to have a heart attack? Are they having cardiac damage? And cool, clammy skin. Granted, that's not skin cardiac, but it happens because of skin. So what's our neuro effect?
Decreased level of consciousness.
Yeah. Altered mental status, agitation, those are these are key words that mean that someone's not getting oxygen to the brain. Yeah, irritability is another one, restlessness is another one. So those are kind of key words that they're just not getting enough oxygen. What about the renal effect?
Decreased urine.
Yeah, we talked about decreased urine output. What happens with that? What else happens with that? Dark urine, yeah. Because it's now becoming more concentrated.
Would you have calcium in your kidneys? Like
Yes, I'm gonna start calling on people because everybody's just. But yeah, dark urine, decreased urine output. Did I do Marley last week?
you were going to do last
I'm just like writing it here. I'm not sure where it's at.
But I said a couple things.
Oh, I lied.
I said a couple things.
Doesn't matter.
Okay.
I think I just mixed them up by accident. All right.
Yeah, I know.
So our map is gonna go down. So it's gonna go under 65. We wanna keep that, what is part of, well, usually vasoactive medication, BUN gets elevated, creatinine gets elevated, anuria, either low, which is no urine output, or low urine output. What about our hepatic effects? What's our hepatic organ?
Liver.
Liver. So what's happening to our liver? What are we gonna see when that starts to break down? If you guys remember, just like what happens with each organ, it makes a big difference. Which elevated liver? What are the liver enzymes? You're right. AST and ALT. Jaundice. Good. Cirrhosis could lead to cirrhosis,
Fatty liver.
fatty liver. What else does our liver help us do? Hmm? Filters waste. I know you're thinking.
Does it release insulin?
What about our waste? Okay, susceptible to infection. It does help with susceptibility. GI. You're just gonna see lack of bowel sounds, maybe some bloody diarrhea. So strep ulcers, you might see starting to see some bleeding, and hepatic effects. Where are those? We talked about clotting cascade. So we might see prolonged PT, because remember PT and PTT, those help with clotting. So you might have maybe that time span gets longer. So there might just start seeing some oozing and bleeding with the patient, and that's called DIC, when it's called this clotting cascade, where your body is bleeding and sending out little microclots everywhere. I have a slide on it, I think, coming up. And, but your body can't keep up with the bleeding, because one, it's sending out all these little microclots that are immature, they're not doing their job as well. Decreased platelets, because those are getting used up. So you'll see the patient bleeding or oozing blood, mouth, gums, IV sites in the urine. I have petechiae. Is petechiae ever normal? No. Bruising. So medical management, the biggest thing is oxygen. We got to deliver the oxygen to the patient. Medication depends on what the blood pressure and heart rate are doing. Is the blood pressure low? So we might need to give some vasoactive medications. Nutritional support when the patient is past that acute phase, more healing phase. We want to keep glucose under control, which is below 180. It seems like a lot, but we need to keep that glucose, because as our body gets injured, it increases our blood glucose. Protonics, anything that reduces histamine or H2 blockers would help also, because we want to decrease the GI ulcers and bleeding. Usually the patient's in ICU because we're going to be monitoring, we're going to be giving medications. If it's, they'll probably be on a ventilator, and then if it's due to cardiac, they might be on a balloon pump, but we'll get into that post-cardiac path. Biggest thing with shock, recognize it early. We want to recognize that map, keep that map above 65, because it promotes tissue perfusion. Medication-wise, it's vasoactive medication, because there's different medications for each shock, depending on their symptoms. Provide comfort, rest, and reduce kind of any further damage, reduce infection, or prevent further damage. How do I say this? And this is just the refractory phase of, meaning that they're probably not coming back. We had a good question. Someone said it was a good question on heart failure yesterday. They told me, was it Lippincott or ATI, or which is the patient that has heart failure? If someone is already in multiple organ dysfunction, they're not going to probably survive that. So it becomes more caring for the family, kind of those last, what are the family's wishes? So if you're taking test questions on ATI or the NCLEX, if there's you're at a point of no return, it becomes more, how do we keep the patient comfortable? How do we keep the family in comfort and stuff like that, but still doing what we're doing for the patient? I think that's it for that. So then now we're getting to this week. So depends on the, shock is always occurring from something, so we have to treat that underlying condition, like our respiratory failure and ARDS. We're treating that underlying condition. Nutrition is important to give your body energy. We talked about the antihistamine 2 blockers. Sometimes they're going to be in metabolic acidosis, so sodium bicarb if that pH is so severe. But like I said before, we want to prevent those complications, prevent further infection, rest, comfort. So different fluids are given, crystalloids, colloids, and blood products. Your crystalloids are all your salines. And your colloids are like your albumin. Some of you might have given albumin in the clinical setting. That just is, it restores your vascular volume. It's highly viscous, I guess I want to say. So it pulls in fluid into the vascular system. And then we have our blood products, which are packed red blood cells, plasma, whatever. The most common and serious side effects of fluid replacement, if you think about it, we're giving somebody with all this fluids, if their heart can't handle it, now we're going to start having some fluid on the lungs. So we're overloading that cardiovascular system, so that's why we're going to get into pulmonary edema or acute, I think that's MI, cardiac syndrome. The anti-diuretic hormone that is released in your renin-angiotensin system, that is being released to pull in fluid to keep it within the body and not urinate it out. So it just does what it says, the anti-diuretic hormone. So we're going to get into some medications. So this is a heavy we're going to have a lot of medications on this test. That's what it is. You're going to need to know what the medication is, why it's giving it, why you're giving it, when to give it, kind of what class it is. I think I want to say that. But I set up, there's a couple of things on Blackboard in the student resource that might help you categorize the medication so it makes a little more sense. I loop things together just to make it more sense for me. So our inotropic H's, these are dobutamine, dopamine, epinephrine, and Primacor or milrinone. So these are our inotropics. What they're doing is they're squeezing the heart a little bit harder, letting blood flow out. And if you think of a sponge, like a kitchen sponge or a work sponge, if you put it in a bucket of water and then you take it out and you just give it a little bit of squeeze, only a little bit of water comes out of that sponge. But if you give it a really tight squeeze, more water is coming out of that sponge. And that's what inotropics do. They squeeze your heart a little bit harder, so more blood, so you have more cardiac output. It doesn't increase your heart rate, and it doesn't do anything to your heart rate at all, or blood pressure. It just squeezes your heart, and that's called contractility. So things to watch out for this. It does, like I said, improves contractility, so it's squeezing our heart a little bit more. It increases that stroke volume, so it increases our cardiac output. More blood is able to leave the heart to get to the rest of our tissues with it. But the thing is, it does increase the oxygen demand of the heart, so it does make the heart use up a little bit more oxygen. The other type of medications are vasodilators. These are nitroglycerins or nitroprusides. These are massive vasodilators. So if you have a patient that's hypertensive, and I'll get to why someone in shock would be hypertensive, we're going to give a vasodilator. But these are usually given on a pump. We don't give these IV push. Nitroglycerin, you can do the tabs, you can do a paste, or you can do IV drip. You're not gonna do it IV push or anything like that. But with these medications, as you can imagine, reduces the preload, reduces the afterload, reduces the oxygen demand on the heart. But it can cause severe hypotension. So if you have a patient and having a neurogenic shock, blood pressure is 180/91, what vasodilator can you give? Would it be appropriate to give this medication? Yes, because their blood pressure is 180. What if their blood pressure is 88/60?
No.
We don't want to give it because that it's going to cause cause further hypotension. Vasopressor. No, so now we're on the opposite end of it. So this is going to increase increase the workload of the heart. It causes vasoconstriction. So it's increasing your afterload, and I have a picture of afterload and preload, and I probably should explain it now, but preload is the amount of volume going into the right atrium. So it's the amount of blood going in there. So if you have more blood going in, say you're hypervolemic, meaning too much fluid, you're going to have increased preload. Afterload is like are you vasoconstricted or vasodilated? So if you think of like a little wrench, I'm going to show a picture just because I got it. Oh, I don't know where it's at. Hold on. There is a picture in Blackboard. So here's our preload and afterload. So this is preload is the amount of volume going into that right side of the heart. Afterload is this wrench. See this little wrench right here? So if it's tight, like it's very vasoconstricted, this left ventricle is using a lot of force to get blood out of that heart. So that if you have a high preload, that wrench is very vasoconstricted. But if you have a low, did I say preload? Sorry. If you have a high afterload, that wrench is really constricted. If you have a low afterload, it's you're vasodilated, this wrench is opened, it's not this tight, so the heart is like beating, getting blood out of the heart and saying, okay, it's a little bit easier to get blood out of this heart. That's what our heart is telling us. So when we're giving medications for shock, any cardiac thing, this is what we're looking at. We're looking at the preload and afterload. I don't have a cursor associated with this. All right, let's go back to where. Is this where I was? Okay. So as you can see, it increases afterload because vasopressors. We're constricting that vessel, so the heart is working harder to get stuff out of the heart. And it increases the workload of it uses more oxygen consumption, and because of that, they might have less perfusion to the skin, kidneys, lungs. So what would you do if you had, what would happen to your urine output with this? It would decrease. So if you have, you're on any kind of vasopressors, it decreases your urine output because it's conserving all that fluid to stay within the cardiovascular system. Considerations when we're using medications is extravasation. I tried to say this word yesterday without looking at it. I did a pretty good job, actually. So the problem with those medications is it's got to be given through a central line, a PICC line or a triple lumen, because they're highly vesicant. So if if it's given through an IV, like peripherally, like what you guys are used to at clinical, if it infiltrates, it can cause all these problems to the skin. Blistering and all that, and just necrosis to the skin in the area. So we're checking that IV site every 15 minutes because we want to check to make sure that it's not infiltrated. Tissue necrosis, sloughing. We're gonna make sure they're on the cardiac monitor because we're gonna be titrating that medication according to their blood pressure or MAP. So we're really looking at what's going on cardiovascularly. And then frequent vital signs, maybe every 15 minutes, depends on the medication. And you're going in and changing that rate on the pump every 15 minutes if you have to. So there's different types of shock. I would know these different types of shock. The first one is what a lot of people associate with shock is hypovolemic shock, the loss of fluids. So we have low circulating volume. Our goal is to restore that blood volume within the body. So we're either stopping the bleeding. If it's due to burns, we're going to treat the burns. If it's bleeding, we're going to stop that bleeding, put pressure on that bleeding. If it's due to massive diarrhea or massive vomiting, we're going to treat those. It's just loss of fluid. It doesn't have to be blood. It could just also be fluids. But a lot of people associate it with just blood, even though there's a knife in the middle of his chest. See, I didn't make this picture up. The other one is, so who are our risk factors for these people? Who's our risk factor? Does it say it on there? Who do you think? Besides the stabbing wound, gunshot wound, what'd you say? Old people, why? Why would someone be at risk for hypovolemic shock?
Little kid.
Why little kids? You gotta tell me why. Injury. So what type of injury? Fall. Old people with a fall and what? Just because they fall doesn't mean they're gonna have hypovolemic shock. But what are they taking? What do most old people take? They fall, they hit their head. Now we're talking a different story. They're gonna have to get increased because they're already at high risk for bleeding. That's why we have those trauma 2s in the hospitals, because someone fell, hit their head, and they're on an anticoagulant. So we're watching for that. But any kind of accident, motor vehicle accident, where it did something, they get hit so hard that something came loose inside. Firefighters, why are they at risk? Falling off the ladder? Oh, burns, yeah, that's true. Good point. But yeah, so think about the risk factors for each type of shock, because you will need to know that. So cardiogenic shock, this is just a shock that someone has a heart attack, has an MI. So over 40% of that heart is not working, of that left ventricle specifically. That left ventricle is shot, it's not working, over 40% of it is dead, so it's not working the way it should. So you're gonna have cardiogenic shock. So the heart is not pumping blood out to the rest of the body because it's not working as well. And that is called cardiogenic shock. Cardiac tamponade, we didn't talk about that last week. PE, any kind of valve disorder, tension pneumothorax. Why would tension pneumothorax be? A lot of tension on the heart. Remember, we got that tracheal deviation to the unaffected side, so that heart goes with it, and it's pulling and tearing and putting compression on that heart. That could cause cardiogenic shock. Now, ventilator, I'm just saying this because I want to make a point, but remember the ventilators, they put, as you increase the lung, it puts pressure on the heart, so you'll have decreased cardiac output. It would, you'd manage it to an extent before they go into cardiac shock, but I just want you guys to realize any kind of pressure on the heart doesn't allow cardiac output, and also any kind of damage to the heart. Just the heart is not working. So you see it there, is the causes. So anyone that, maybe you'll see someone come in with an MI, so they're at risk for cardiogenic shock. The whole goal is to limit that damage. So what are we doing to limit further damage to the heart? The other one is distributive shock. Now, there's 3 types of distributive shock, so you'll need to know each one. So this type of shock is massive vasodilation. So all of our vessels are vasodilating, so fluid is getting leaked out. And again, there's less blood leaving the heart because of it, because of the vasodilation. The first one is anaphylactic shock. So release of histamine is causing that vasodilation. Neurogenic shock is when there's a spinal cord injury and it suppresses the sympathetic nervous system. And then septic shock is from inflammation, from an infection. So there's no bleeding here, it's just massive vasodilation. But with shock, the whole thing is there's less cardiac output. So it's either less cardiac output from massive vasodilation, from the heart nerve not working as it should, or just bleeding. And that's it. But we'll go into each one. First one is sepsis. This is important to remember. They're really pushing this in the hospital and coming in from the ED. We're always looking at someone that's at risk for shock, or sepsis, I should say, but it is a life-threatening organ dysfunction. It starts with an infection, and it's an infection that's gone bad. You and I, we can fight off infection pretty easily, but our immunocompromised people are someone that might have cancer, older people above 65, they can't fight off infection like we can, so they're at risk. And if you look at just those symptoms that go into sepsis, heart rate above 90, respiratory rate above 20, white blood cells above 12 or below 4, and then a temperature above 101. So those are not very crazy. But the history is they have an infection also, and then it's triggering this, and then with these symptoms. It's kind of, I don't want to go there. But, so here's our immunocompromised people, malnutrition, large wounds, just anyone that has infections. If they have a PICC line or central venous line, they're at risk for shock. So let's go over this shock type question. So when you're taking who's at greater risk, when you're taking test questions, literally count them. Go, okay, someone that's at risk for sepsis, they have pneumonia, they have PICC line, they have history of alcoholism, and diabetes. That's 4 risk factors. What if I have another patient that has a UTI and has a large wound? That's just 2. So count your risk factors when you're doing who's at higher risk, because whoever has more is the winner, is who you're going to pick. One is not more important. Pneumonia is not more important than UTI. They're equal, and so is like alcoholism. It's equal with pneumonia. No one trumps another. So just count your risk factors, and the one that has the most is the winner, and who you should be picking. Okay. So there's different, I'm not going to go into manifestations because we already did that. There's these do not ignore alerts. So we had this at clinical with a patient that you sign into the chart and you get an alert saying, hey, your patient is at risk for shock, your patient is at risk for whatever, heart failure, I don't know what they are. I know it wasn't shock though, someone had it.
Heart failure.
Was it heart failure? But what the chart, it's an EHR, electronic health record, is saying this patient has an infection, and now I notice that their heart rate is above here, and they have high white blood cells. So it sends out this alert to to the nurses that sign into the chart, and we're supposed to alert the doctor, the team lead, or A&M, to let them know just, hey, this patient has the symptoms of shock. We need to start early treatment because we don't want it to get further along. DIC, this is, disseminated intravascular coagulation. So this is a complication of shock. And what I said, like I said, it's, the clotting becomes overactive. So our body is recognizing that we're bleeding somewhere or we have some issues. We don't have enough, our PT values or our PTT values are getting prolonged. So our body is now starting to overproduce like microclots. It's just sending out clotting, but they're not effective because they're immature and they're not adults yet. So they're not doing their job. So the clotting cascade becomes overactive. Lots of blood clots happen, but it's also, they can cut off like your capillaries because we're sending out more blood microclots, and it could clot off other areas in the capillary. So our liver, brain, and kidneys can be shut down because of DIC. And like the PT becomes prolonged, hemoglobin, what does that do? Goes low, like it says. Platelets go low, hematocrit goes low. But this is a complication. You'll learn more about it next semester in maternity. Fun stuff next semester. We're already in week 6. Multiple organ dysfunction syndrome. This is when one or more organs, or really 2 organs, shut down. Usually the shock isn't recognized early enough that so multiple organs are starting to shut down. Mortality rates increase with the severity of sepsis. That's why it's so important for us to recognize it early and with those sepsis alerts or on your own. Maybe you don't wait. I've had experience where this patient came back from surgery and you see their heart rate start to go up, their blood pressure start to go down. So you have to look at those trends to make sure that and I'm looking, okay, this guy just had surgery. I'm starting to heart rate go up, blood pressure go down. Now I'm starting to worry that they're in shock. So you want to make sure we call the doctor and address that sooner than later. So maybe they have to go back in and do something. Maybe they need some vasoactive medications to keep that blood pressure up. So you always have to keep their history in mind and be looking at those vital signs and trends. Carry out treatments for what the underlying condition is, whatever the type of shock it is. We already talked about complications with multiple organ dysfunction, ARDS, because now those alveoli are starting to shut down, DIC, and we've already talked about all these when our organs start to shut down. That's why I say if you keep it into organs, it's a little bit easier. This is an example of what you see in the emergency room, or now they have these bundles, sepsis bundles. I don't know, I think this is a 3-hour one. Well, I don't know what it is. But there's bundles. There's usually, if they're at risk, they're gonna do step 1. There are these order sets, what we're gonna do for this patient. We're to put them in categories. Are we gonna give fluid boluses? And just to recognize it early, and there's proper protocol for finding, well, when they're identified at risk for sepsis. But there's 1-hour bundles now, 3-hour, like within 3 hours, we're gonna do all this. Within 6 hours, we're doing all this. Within an hour, this is what we're doing. So you need to be on the alert. This is someone that typically looks like someone with severe sepsis. They're on the ventilator, they have fluids running, antibiotics, vasopressors. There's a lot going on, that's why they're in the critical care unit, because you can't take care of 4 people like this. That's a lot going on. You need 100 hands and brains. But that's typically what somebody looks like. Sepsis, health promotion, just decrease your risk of infection. Don't share utensils, monitor your temperature, monitor your urine output, make sure it's nice, clear, and yellow, or it's supposed to be clear, period, look like water. If not, you drink more water. If you have any wounds, make sure you're monitoring your wounds. Anything that looks like an infection, make sure you're monitoring for. We're going to move on to anything about sepsis. They're really pushing sepsis in the clinical setting. That's why I spent more time on it. So neurogenic shock. This is the other type of distributive shock. This is where there's a spinal cord injury above the level T5. So this could be a fall also, or it can be a accident. But there is a spinal cord injury above the level T5. The biggest thing that is different about this from all other shocks is they have warm, cool skin, and their heart rate is down. Sorry, warm, dry skin. So you have warm, dry skin, heart rate is down. So I always think the brain wants to do whatever it wants to do, so it's going to be different. So with neurogenic shock, those vital signs are all low, bradycardia, and they have warm, dry skin. Just because that sympathetic nervous system is out of whack, is being blocked. So that's why they have the low heart rate and warm, dry skin. For treatment, we want to stabilize that spinal cord. So maybe surgery, keep the head of bed about 30 degrees if it's not contraindicated. But we want to, of course, increase the cardiac output. Management steroids, atropine, because atropine increases your heart rate. Steroids because it decreases inflammation. And they might be on IV steroids for about 24 hours. And then anaphylactic shock. This is somebody that has allergy to bee stings, contrast dye, antibiotics, peanut butter, eggs. I'm trying to think of all the Hallmark ones. They're probably up here. Peanut butter, did I say that? Shellfish, that's another one. These are all, you need to be on the alert for anyone with these allergies. I had a patient once, well, I was just getting there or something, but the patient left already for a CT scan with contrast dye. And I was literally just writing out my paper, and I saw he's allergic to contrast dye, and I'm like, ooh, we gotta stop that. I called down there, and the nurse tells me, oh, he only has one kidney, and I'm like, oh crap. We were about ready to put that guy in renal failure. But you gotta pay attention to allergies, make sure that they're, especially shellfish or contrast dye. Well, all of them really. Educate them, carry an EpiPen, wear a bracelet with the antigens on there, so if something should happen, you come upon a person that's passed out, but you see it, I don't know, there are bees around, and you have an EpiPen in your back pocket, you know that you can give them the shot. So educating about wearing an allergy band and carrying an EpiPen. And signs and symptoms. So they have usually itchy throat, hives. They're more of a allergic reaction symptoms than the other ones. All right, I'm gonna skip over these. I'll get back to you. Oh, let's go with now that you just saw the answers. All right, a 65-year-old male with a history of chronic COPD arrives at the emergency department, shortness of breath, decreased breath sounds, heart rate 112, BP is there. Which type of shock is likely with this patient? I don't know. Well, he has a history of COPD, arrives with shortness of breath, decreased breath sounds. I don't think I like this question. Why B? Well, they definitely, how do we know that they have shock, first of all? Low blood pressure, high heart rate, so they short of breath. I don't like this question. This is a bad question. I'll just be honest with you. So, what if I said this patient, we need some other information, right? What if this patient has cloudy urine? Septic. What if I said elevated troponin on lab values? We haven't gotten there. Cardiogenic, so now they're having probably a heart attack. Hypovolemic has an open, profuse bleeding wound. Or excessive diarrhea. A. And then anaphylactic is any infection. But the answer is hypovolemic, but nothing in there shows that this patient had something. So this is a bad test question. And I would give everybody credit for it. Okay?
Go ahead and add that.
All right, 30-year-old female with multiple allergies experiences sinus wheezes, facial swelling, difficulty breathing with an injection of insulin. Blood pressure 70/40. What is our intervention? C. Why not B?
Well, also you said insulin about penicillin.
Did I say that? Penicillin. So yeah, C. We want to administer the EpiPen. Monitoring vital signs, we're not going to do that because they're already 70/40. Started infusion line, is that important to do?
Yes.
Yeah, but getting that epi in first is important. And then we'll probably give Benadryl too. All right. Let's just do cardiac stuff, like an introduction. So cardiac valves, when you're doing cardiac, when it's getting to heart failure and cardiac valves issues, know the blood flow through the heart. There's a picture of a heart and the blood flow. If you just remember that, you can figure out signs and symptoms. You can figure out certain diseases because the diseases is in the name of the valve or the atrium or the ventricles, so you could kind of figure out what their signs and symptoms are just by knowing the blood flow through the heart. So what are our AV valves? Which one are those? Our
Tricuspid.
Bicuspid valves or mitral valve. So our mitral valve has two names, the mitral and the bicuspid valve. The reason why it's a bicuspid because they have two leaflets where you can't see it on this paper, so it doesn't matter. But the tricuspid has three leaflets in that valve. And we always want to try a car before we buy a car, right?
Mm-hmm.
We want to try something before we buy something. So that's why your tricuspid comes first in the right side of the heart, and your bicuspid or mitral valve is in the left side of the heart, because we try something before we buy it, right? So your tricuspid valve comes first. Oh, and then the semilunar valve, which one are those? Pulmonary and aortic valve. Pulmonary valve is coming from the artery or the pulmonary system. And then the aortic valve is the valve that goes out to the heart. So know the blood flow through the heart, just memorize it. You probably had to do it in A&P. You're going to have to do it here. Things are for a reason. Coronary artery system. So our heart has its own blood supply. So when someone's having an MI, this is the blood system that we're looking at. Because blood is getting shut off to the actual heart muscle. So when someone has a myocardial ischemia, we're talking about the blood supply to the heart. And then the arterial system is the rest of the body. That makes sense? Where the coronary system is just to the heart, and then the rest of it is to the rest of the body. So myocardial perfusion, how do we know that? What are we looking at? know our myocardial is getting perfused? MAP? Well, that's the second one. What's our MAP score we want above? 65, okay. But coronary perfusion, making sure that coronary is getting perfused. We're looking at our MAP because that means our kidneys and our other tissues are getting perfused. Cardiac output, 4 to 7 liters per minute. Some of this is probably a review. Ejection fraction, what do we want that at?
40 to 60. 55 to
55 to 60. So this is the percentage of how much blood is getting ejected from the ventricles with each contraction. So it's a percent. We're not having 100% of our blood come out of our ventricles with each contraction, only a percentage of it. And then another thing is we're having the patient weigh themselves each day when we're talking about the cardiac patient, because we want to detect any kind of heart failure. Because when there's heart failure, they're going to start to retain fluids, and we have them, if they gain more than 2 pounds in a day, or 5 pounds in a week, we want them to contact their provider. So how do we educate a patient about weighing themselves daily?
Wait with the same clothes on.
Weigh with the same type of clothes every day. You don't want them getting dressed with their steel-toed boots and all that one day, and the next day not have them, or vice versa. Same clothes, same shoes, whatever, same type of clothing each day. All right. We already did that. Let's take a 10-minute break. Let's come at 10:13.